Welcome to the Food Junkies Podcast. Here, we aim to bring you the experience, strength, and hope of professionals working on the front lines in the field of food addiction. Our mission is to educate you, the listener, and increase overall awareness about food addiction as a recognized disorder. Here, we discuss all things recovery, exploring the many pathways people take towards abstinence in order to achieve a health-forward lifestyle. We hope to inspire you to thrive rather than just survive. So stay positive, make a change for yourself, and share your journey with others. And hopefully the message will spread.
Hey there, Food Junkies listeners. When you strip away the labels, diagnoses, and the "you're just in denial" conversations, what's left is a human being doing their best to survive. In this episode, we sit down with Dr. Carrie Wilkens, co-founder of the Center for Motivation and Change and co-creator of the Invitation to Change approach, to talk about what happens when we stop treating addiction as a moral failing or a rigid disease category and start seeing it as a complex, deeply human struggle. Carrie shares how her own history with an eating disorder and ongoing relationship with food informs the compassion, curiosity, and flexibility she brings to her work with individuals and families. Together, we dig into why language like denial, codependent, and chronic relapser can shut people down, and how shifting to questions like, how does this behavior make sense, opens the door to safety, honesty, and real change. We explore how self-compassion, values-based behavior change, and a truly individualized lens can transform not just treatment, but how families, communities, and clinicians show up for the people they love. We're so excited to have Dr. Carrie Wilkens here with us today. Welcome, Carrie.
Well, thank you so much, Carrie, for joining us today. We're so excited to have you here.
I'm really excited to be here with you. Where are you guys, by the way? Can we just clarify, where are you?
Yeah, I'm in Ontario, Canada, and Molly?
I'm in Montana.
Okay, great.
But we work internationally with many people, like in the coaching field.
Yeah.
We love for our listeners. So I heard you recently on the podcast with Holly Whitaker, and I already knew about your information ahead of time. And I was like, our listeners need to hear more of what Carrie has to say. And I know you've also shared a little bit about your own personal history with relationship with self and food. And I'm wondering if has moving through your own healing guided kind of the compassion and curiosity approach you also now bring to your professional life?
Yeah, on so many levels, and is probably still happening. I hope it's still happening. I mean, our worlds and your world are overlapping in so many different ways. And I think people move in and out of, struggles with their relationship with food, and then into different behaviors, and then maybe into substances. And, I think foundationally, our relationship with food is primary, right? I mean, we have to negotiate that relationship. And I think that is, when I work with people who have years of sobriety, they'll still be struggling with their relationship with food, So I just appreciate the lifelong relationship management it takes, and you just your relationships with people change. The relationships with food is going to change over the course of your life, because what my 55-year-old body can manage with food is very different than when I was 25, and I have to accept that. So I think just the process of accepting and understanding and being able to notice what's happening for yourself at any given time in your life, and your relationship with your body is just so profound and foundational and disrupted by so many things. So yes, I think it's still ongoing.
Totally. And that like you said, that understanding and empathy and seeing the journeys that people are on, and knowing you've been on your own journey. Often many of us have. And we're just, I guess we all have our own beliefs about this, but we're really curious to hear yours, as we think about our stories and how they influence how we work. In our field in particular, because it's so new, it's not regulated. We're fighting to get into the DSM and the ICD, under ultra processed food use disorder. But in our world, there's often this belief that we need to have personally struggled with addiction, and specifically food addiction in our field, in order to effectively help the people that we're working with. Now, I come from the world of working in substance use disorder and mental health, and I have never touched methamphetamine a day in my life. And I was able to work with many people, right, to get successfully off of methamphetamine. And so we're just wondering, what are your thoughts on this idea that we have to have this personal story, in order to help the people that we're with? And does it positively or negatively even impact our ability to work effectively with people?
Well, I hope for your field that it shifts over time in the way that it did with mine. And we opened the Center for Motivation and Change, and this is over 20 years ago now. We had a lot of treatment professionals and people in the recovery space who, one of the first questions they would ask me is, and I still get it occasionally, are you in recovery? I used to feel there's not an answer you're going to like here. And then, are you going to judge my capacity to be helpful? So yeah, I know what that struggle is like. One of the questions I think always just asking people, how do you think that would be helpful? And then they say a little bit, and then you can answer, you can tell them your skill set and why you think you are able to be helpful, which, because I did struggle with an eating disorder. And, so I would always say to those guys, I didn't struggle with I actually did struggle with my relationship with alcohol as a young person. I was a profound blackout drinker as a high school student. Any treatment professional would have said, you need to be sober the rest of your life, had they met me at that particular juncture in time. That didn't persist. And, I have a healthy relationship with alcohol. It's never been a problem for me. But I did struggle with food. And again, in an ongoing way, I'm always having to keep track of that. So I do understand, just when you have I will say sometimes to my clients, I'll be I haven't engaged in eating disorder behavior in over 20 years. I know myself well enough to know if I'm in a particular mood and I have a particular access to the food that even 20 years ago was my escape hatch. And, if there's a confluence of things that come together, there's a part of me that feels yeah, I'd be at risk for that again. I can't imagine it turning into a full blown, I'm back into that behavior, but I can imagine engaging in it in a way that's it's just in your memory banks in this way that you're kind of yeah, and I have to pay attention to it. I have to respect it. So I think there is some value to understanding behavioral struggles because you can kind of I think you see patterns. I think you understand the shame. I think you can understand the desire to keep it a secret. But those are also very human things around a lot of issues. People don't like to talk about how depressed they are. People don't like to talk about that they have panic attacks, So, I think as human beings, if we have interest in being compassionate and connected and understanding why are we doing what we're doing, how does this behavior make sense to me? And is it in line with my values? Do I want to keep doing it? Or is it causing me some problem in some way? Somebody who's walking around with untreated panic attacks, that's disrupting their life massively, so it's not food. It's not substances. Their life is constricted and they are suffering and they're in pain. And a big part of them wants to keep it a secret because it's shameful. And we as human beings don't like to acknowledge that we all have struggles. So I think if you just kind of always land in we're humans and I've never met one who doesn't struggle. I might have a deeper skill set in noticing some things because I have my own history, but it doesn't mean if I don't, I can't help you. I'm actually really good with people with panic attacks. I don't have panic attacks. Right. And I'm quite effective. So it's just, I think that gets lost in these kind of little siloed spheres. And that's totally worth challenging. And I'm glad you guys are doing it. Is that helpful? Is that what you're?
Yeah, no, it is so helpful. And I also think, when I hear in predominantly the addiction space, because we both were in the substance use disorder field before we moved to food, was common to hear, this person is in denial. And, how that was the most unhelpful thing that you could say to someone. And I'm also someone who is in recovery, and how that feels when that is said to you. And makes you, it's almost like maybe a professional feels like you're being gaslit, right? And you're I don't know, maybe they're right? Maybe I am just in denial. And so I'm wondering if you were kind of imagining a brand new training program where clinicians couldn't use that word, what do you think would change how they listen to the people they're working with and would be able to conceptualize and also intervene in a more compassionate way?
Yeah, I think that's a great question. We actually just had a whole staff meeting this morning about, just exploring kind of the words that in the recovery, addiction, treatment landscape just get used like as blanket statements. They get said to family members, they get said to clients, like just like you are in denial, you're an addict, you're a codependent, it's a slippery slope, you're in relapse mode. There's all these things that get said that have a bunch of stigmatized meaning attached to them, actually. And for most people, feel bad. They may not verbally tell you that that's making me feel bad, and they may nod their head like, yeah, I know exactly what you mean. I encourage people to, every single time you hear one of these like statements that are just these big whitewashing overgeneralizations, to just be like, okay, so what do you mean by that? Like, because I've had family members say that I'm a codependent. I'm like, I have no idea what you mean. And I would like to understand if that's a helpful way of understanding yourself. I want to know, so that I can partner with you. But for me, that word means 100 different things for 100 different people. So I'd rather unpack what are the things that you're engaging in that feel problematic, and that you would like to shift. So I just think there are ways of thinking we know something, when if you take that word away and start to ask questions and express a lot of curiosity, there's a whole world of additional information in there, and a lot more meaning and a lot more avenues to change the behavior, right? Because that's the other thing, is like these words that say, okay, I'm an addict, right? So there's a lot of meaning in that for people, and it kind of implies that there's one path that you can engage in that's going to get you out of it. And if you don't engage in that path, it's not going to work, right? Because you're really an addict. So it just restricts things down versus being like, okay, I'm struggling with this behavior. These are the ways that I engage in it. This is what I get. This is how the behavior makes sense for me. This is what I get from it. This is what's compelling about it. This is what pulls me to it. These are the things I don't like about it. These are the things that are against my values that I'm doing. And there might be 100 different pathways to change that behavior once you unpack it, and give people real permission to tell you what's going on with it. So I just think a lot of information is lost, and that for treatment providers and family members, because family members get in a real bind because they think my loved one is this thing. Your loved one is so complex, and this problem that's in your house is so complex. Let's just talk about it that way, because you're gonna feel better, you're gonna understand it better, and we're gonna be able to be more strategic. So I think that's the problem, is people want to fast track this and they want it to be easy. It's so complex, and behavior change is so slow, and people don't like that part either. So
no, it's so true. We talk a lot about language with our clients as well, and like that it matters. And when I think about this word denial, like I think of being an active participant in something that I'm denying. And so often this word gets thrown around to people who are not even like they're in pre-contemplation. Like if we think stages of change, like many of times this is being thrown at somebody who doesn't see that there's an issue or doesn't believe that there's an issue for whatever reason. And then we're using these words, and it's just an opportunity to, like, we're just shutting them down. Like you said, we're really constricting like these options that somebody might have. And so I think that's one of the things I really enjoyed most about listening to some of your previous interviews and just reading some of your stuff, is that to me, you're like what my husband would call a disruptor. And I think that like Clarissa and I really take that on as well, where you said you've been around for 25 years. I've been in the field for 20. And I wish that 20 years ago, I would have known about you, because it has been so lonely until I met Clarissa, right? In the last couple decades, because language matters, just like questioning things. I've questioned these things from the beginning, in your interview with Holly, and you talked about like traditional treatment and it really coming from these 12-step models. And I've always believed there's got to be this other way. And so, many people will, label somebody like yourself or us even like reckless, because we don't necessarily adhere to this like very clinical idea of this being a disease, and that when we don't do that, then it's unsafer, that we're potentially putting clients in harm's way, because like you said, like we're not like if it's an addict, then it has to be treated like addiction. And aren't they more complex? Aren't the people that we work with more complex? And so I just wonder, like, how could we, do you have an idea, or what do you wish people understood about how we can maybe soften that idea of this being like a disease or the disease model without softening the seriousness of addiction, which is absolutely a disorder, but I don't know. I don't know that it's a disease.
Yeah. Well, that's a whole nother podcast.
Right. Yeah. You're welcome to come back anytime.
And I kind of ground. So a couple of things. I think part of the thing that you named earlier around people's wish to kind of just label everything as in denial or and not being very curious about what's going on and really wanting to pathologize things and say this is a disease or this, whatever. These problems are scary. Like they're scary for the people having them. They're scary for us to witness. But I think in this country, we have collected the evidence that punishing people and scaring people are not really changing the problem. In fact, the problem is growing, right? So we're clearly missing something in those two strategies. And I think that some of the disease model, the anxiety that pops up if you don't talk about it in a certain way, or if you say like, yeah, some people relate to that. And then there's a whole swath of other people who don't relate to that. And in fact, you're turning them away. The people who get anxious about that, it's just coming from fear and fear that that person isn't going to get the help that they need. And which brings me back to what I said before, which is behavior change is very slow. It's a windy road for most people. So, and that's hard to tolerate. And what gets somebody into kind of change mode, it's different for different people. And like that denial, like it's such a stigmatized problem to have. Like nobody wants to have a substance use problem. Nobody wants to struggle, be binging alone at night or potentially throwing up, like nobody wants to have that. It feels horrible. And then we live in a society that shames and says in so many ways, you're a bad person, you're out of control, like you're selfish, you're like, there's all these conscious and unconscious messages. So when somebody says that person's in denial, I'm always like, what's making it so hard to talk about what's actually going on for them? Like what's the context around them and their relationships in their world? What have they heard about treatment? What kind of help have they had in the past? And usually there's a lot of painful stuff there that is making it so they don't want to come forward with what's actually going on, or that behavior is working for them in ways that we don't understand yet, right? Like if I'm drinking to put myself to sleep because I'm having flashbacks about the childhood sexual abuse I incurred, I may not want to tell you that. That drinking might be very scary for me to give up. So I might keep doing it, even though you're trying to talk me out of it. There's so many layers there that, again, like I think people just want to crash through that and get to the finish line, right? Because it's so destructive. And that might take a very long time for that person to be open with what's going on with them. And I think that's true with food too. I think there's so much shame around struggles with food.
Yeah. It's even when we talk to clients and we say like, okay, well, what was the wisdom of the binge in that moment? They're like,
right.
That's the problem. Right? That's the problem. I'm like, no, that's the solution. Probably the problem was happening before, and we can explore that a little bit more.
That's a lovely language, by the way. I mean, that's our version of that is like, how does that behavior make sense? Did it work for you? What did you get out of it? And I don't mean that sarcastically. I actually really want to know. The most important thing, I'm like, you can tell me about the cost all day long. If I don't help you figure out the benefits, and if we don't figure out what it's doing for you, it's not going to go anywhere. So please tell me.
Well, and I also love how you said we don't talk about how long behavior change, takes. And we know from like the recovery research done by Recovery Research Institute and John Kelly, it's like 7 or 8 years for most people once they start to decide to stop to even get 1 year abstinence, multiple return to uses, but most of those will be abstinent days. But like, how loving would it be to know that ahead of going in? To be able to say, hey, this is going to be hard. There's going to maybe be some slips, some reoccurrences. And if you keep going, we also know that, the majority of people will get into recovery as well.
Right. And I would argue those numbers the years are well past 7, to real, because that's tracking a change in one relationship with one substance. So many people will be like, yeah, I'm abstinent from alcohol, but I'm struggling with food or I'm gambling or I'm doing these other things because I actually don't know how to do something. Yeah. Like I don't know how to emotionally regulate. I don't know. This underlying issue is still impacting me and I don't know how to manage that yet. So the on the surface behavior, that looks like the problem is usually not the real struggle. It's like, what's that behavior doing for you? That's the struggle. And that's where and that's a lot of skill. Like I tell the people all the time, I'm like, if you're going to ask somebody to give up a substance or give up highly processed food, whatever it is, if you're going to ask them to give that up, they have to learn to do that. So there's a lot of learned behavior around not engaging. And then they have to learn a bunch of behavior that works in some way to replace that behavior, right? That stuff doesn't work right away. And you're going to have fits and starts, and it's never going to work exactly like that. I mean, you mentioned crystal meth before. I tell the people that I work with, like, nothing's ever going to feel like that, ever. So we still need to put a lot of behavioral replacements in place, but that is in your memory banks, and that doesn't exist in any other kind of thing. So then you're having to help people deal with, and I have a loss. I'm having to lose
my main coping. Yeah.
Yes.
Yes.
Or the people that were associated with it, or, so that's just so much learning. And there's so many things that we don't rush, right? Like, we'll give somebody time to learn to play the piano or learn a sport. And we give you lots of different coaches and we give you lots of different things. And we think that's okay. When it comes to these behavioral problems, we just want you to figure it out.
Stop immediately.
Decide you want to change.
It's like, oh, you want to run a marathon? Okay, you just need to go tomorrow. No training, no practice. I'll see you at the finish line. Right. And it's just not, I feel like it really sets people up for, what they are going to feel like is failure because they haven't gotten the chance to practice. So speaking of people having a return to use or maybe a reoccurrence, or even sometimes we call it a rediscovery, you have described relapse as returning to an old behavior that once worked. And if all we ever said was, oh, I changed my mind and tried that old solution again, that's actually so much softer, right? And seems to make so much logical sense and is probably okay for everything else but substance use disorder.
Yeah, no, that's just a perfect example of saying it that way, of just it's an old behavior that your mind decided might work again. And it might actually, right? So there's that. And to just be able to talk about that, because when we don't talk about it and we say all right, maybe you weren't serious, maybe you didn't really want to change, which is what family members, they see that behavior and they're like, maybe you didn't want to change, or you're just going back to your old ways, or all of these kind of things, versus being like, wow, what pulled you back to that? What's hard about staying in this place that you looked like you were doing well in and that you appreciated, can we just be curious about it so that you can, because again, if that behavior goes underground and it becomes like something I have to keep a secret, it's like something I'm engaging in that's making me feel bad, that there's something about that secret keeping, shame-filled space that is so painful for people. And the behaviors can kind of blossom there in a way that is just painful. And I think if we can find ways to just keep the behavior on the surface and not overreact to it, shame it, lecture it, it just doesn't pick up as much energy. It's like shining the light on. Just keep the light shining on everything. Be curious about it.
Yes, it's so true. I'm a big fan of solution-focused free therapy, which is very similar to motivational interviewing, and I've done it all. I think the thing that I love most about solution-focused, though, is I don't really have a dog in the fight with motivational interviewing. We do a little bit, right? We're trying to get people to that change, where solution-focused is whatever answer you give me. And I really love that because it does remind me to stay curious. I ask the question and I literally have no idea what's going to come out of their mouth. My only job is to make sure I'm asking good questions and I'm meeting that person where they're at. And, everything that you're saying, just keeping that curiosity open instead of going to that place of well, obviously they didn't want it enough, because if they did, then they would have called 3 people and they would have gone to a meeting and they would have X, Y, and Z. And at the end of the day, you said, everybody has, they're not going to tell me that they're having, flashbacks from this thing. And that's why, the substance, was the easiest thing to return to, because there's a skill gap and there's a support gap, there's a resource gap, there's some kind of gap going on, and my brain just wants to survive. It doesn't want to feel this pain. It just wants it to go away so that I can be okay. And so, yeah, go ahead.
No, I'm just agreeing.
Actually,
lovely description of it.
Yeah. So I just think about you and the model that you use. And for listeners, maybe who are maybe just getting their first introduction to you and, the invitation to change approach, how would you describe its core principles, the philosophy, if people are curious to know how you work with others? Yeah.
Yeah, sure. Yeah. The invitation to change really came about because, we were We are trained in motivational interviewing. And your description of that was interesting to me because like I actually I approach it very much from I don't have anything in the game here. My job is to just create space for you to be able to think about yourself without being defensive because I'm trying to talk you out of something. I mean, it's like really like my job is to just create space to like actually be with your ambivalence.
Which I totally love. And it's probably because I was taught from like old school individuals.
My little spidey senses got up there. I was like, you got taught by somebody.
It's probably the old school teaching where like my spidey senses were like, that's not for me. Like, I want this other way. Yeah.
Yeah. So we're grounded in the legitimately, I don't have any skin in the game here. My job is to be here with you to help you understand yourself better and decide what changes you want to make. And then, we're all trained in acceptance and commitment therapy, which is, very much grounded in helping people kind of anchor themselves in their core values, which are different for every single person, and really giving them permission to think about that and identify those and then use those values to move through the discomfort of making changes, right? Because anything that we do, discomfort is part of it. And, you got to kind of have your core value reason to get through that discomfort as your reason, right? So we put a lot of reason for doing difficult things, which change is difficult. So the acceptance and commitment part of it, the motivational part of it, the biggest part that I appreciate is the self-compassion part. And have you guys ever attended a self-compassion training? Have you done that? Yes. Yeah, good. Makes me happy when people nod their heads because when I just gave this talk to a room of 200 people last week and there wasn't a single hand, I was like, oh no, you guys have to go, like, please. Because it was like a room full of care professionals. I was like, self-compassion as a skill, like literally changed my practice. And I was somebody who was like super skeptical. I was like, that sounds totally hippy dippy. And I'm not, like I was really not into it. And then during the pandemic, did a couple of trainings. I was like mind blown. Like, first of all, I'm terrible at it. And I've now practiced it and appreciate it. But I think from a behavior change, being in the world, trying to be helpful, trying to understand yourself, like actually finding self-compassion is such an antidote to the shame. It's an antidote to the pain that so many people are in. It's an antidote to the isolation that surround to all of these problems. So the invitation to change has a lot of self-compassion infused into it. So we kind of try to help people understand from a behavioral perspective. It's like behaviors make sense. How does this behavior make sense? What's it doing for you? The ambivalence is normal. You're going to be ambivalent. It's not a bad thing. In fact, you got to understand it. You got to understand what's pulling you back to that old behavior. The one size doesn't fit all. Because like what works for you, it's not going to work for the person next to you, I think that's part of the power of the 12 steps. It's like you have a room full of people that worked for in such a powerful way. So it feels incredibly powerful. They want to spread that, right? Which is awesome. It worked. Awesome. But to be able to really stay grounded in it doesn't work for everyone. Really, it doesn't. And we've got to open the doors to being curious about, all the ways that people can make changes. And one of the things I say all the time is like, not everybody's going to go to treatment. Like, there's entire communities who are never going to go to treatment. Like the one size that fits all for that family and that person trying to, maybe the community elder, maybe a faith-based leader, maybe a new sport, like who knows, so helping families and people being really open to one size does not fit all very genuinely and being able to be curious about that. The self-awareness piece. So like, what part, like how am I regulating my emotions? What are my personal values? The self-compassion piece. And then the behavioral piece is where everybody wants to start. So it's like, how do I change? How do I have my relationships be different? You got to kind of understand this other stuff first. But there's a variety of communication strategies that just enrich relationships, allow conversations to happen in a different way. And then the behavioral strategies, which is like, how do you reinforce and support the changes you want to see? And how do you, put some frame around some of the stuff that you're trying to discontinue, and make that not so rewarding, essentially, so it's just it helps people kind of step in wherever you are. We designed it as a wheel, because you may have a lot of insight and be ready to step into behavior activation, right? So you can step in right there. You may be like, I don't even know if I have a problem. I got to think about this. So I step in somewhere else. You may be somebody who's like, I really know I have a problem and I've tried to change a lot and I keep not being able to change, and I feel really bad about myself. So enter self-compassion, right? So, and I think that changes over the course of time for people. People need different things at different times over the course of this behavior change arc. And I think we've just tried to build a model that gives people a lot of things at any given stage, and a way to understand the change process. And we developed it for family members, actually. It was developed as a way to help family members help a loved one trying to change. And then we just made it for the person with the problem.
Could you speak a little bit more about that? Because I could totally understand, as like somebody who works with clients, and seeing how the self-compassion is like so nervous system regulating. It reduces the shame. It allows them to be open, get curious with themselves. But what about family members who aren't going through the same process of somebody who is with the substance use disorder? And they, even though we know most of these individuals are working on their recovery every day, the family members and helpers are sometimes only seeing the behavior. Why did that happen again?
Yeah. Well, so the invitation to change really was developed for them as a way to understand those behaviors. So the exercise, the foundational exercise for the family member is, how does your loved one's behavior make sense? Because as a loved one, if I'm just looking at you as, I've been told my husband's an addict, or my kid's an addict, right? That's what I've been told. So then I'm looking at them through this lens now, versus, it's about the addiction. It's about the substance. That's what it's about. That's what I have to keep track of. Any engagement in that means they're not serious, or whatever, the whole host of things, right? Or they need to go to rehab, or whatever. Being able to be like, how does it make sense? Gets a family member to that space of, oh, they're actually drinking because they can't sleep, or they're so socially anxious they don't know how to make friends, or the bazillion other reasons why people use substances, right? That just shifts their perspective. And it also gives them a landscape from which to then be way more strategic. Because then if a parent realizes, like, actually my kid's not smoking pot just to rebel against me and just to piss me off, they're smoking pot because they really are awkward in social situations. They don't know how to make friends. They're being bullied, whatever it is. It allows them to then be like, how do I help my kid with that? And reward them for non-substance using behaviors. It allows them to just engage more actively, instead of the cultural message, which is like, distance yourself, tough love, let them bottom out. Like this messaging, which just gives people nowhere to go. So that's a long-winded way of saying it starts with behaviors make sense for the family members, because then they know how to work with ambivalence. Then they'll be like, oh, they're not going back to it because they don't care. They're going back to it because whatever, the way that it works. Let me see if I can change something in the environment. Also, like how I respond to ambivalence. So if you return to use and I start lecturing you, or I get really mad at you, right? You're going to spend all your time defending why you're doing what you're doing, right? If I respond to that return to use by asking open-ended questions, by expressing concern in a way that doesn't make you defensive, by offering to help in a way that doesn't make you feel belittled, it just gives family members a whole different set of communication strategies that they can kind of engage with their loved one with, which is super relieving, because families with substance use problems, like, there's a lot of friction and there's a lot of fighting, and there's, and they need new skills, and they're typically pretty desperate for it and relieved, when they start to do these things. People will say, like, I'm having conversations with my kid for the first time in years, where we're not screaming. And that's a really nice thing.
Well, I was just going to say, it just makes, it's so supportive in that it feels like you actually get to meet the person who's struggling with like words with hugs versus like, what's wrong with you? Why would you do this to me again? Which is often which people, family members make that person the problem then instead.
Well, and they try to make their person the problem, but they also try to make themselves the consequence. Because it's like, if I'm mad enough at you, maybe you'll change. If I punish you enough, maybe you'll change, which is
You have no idea what's in my head. I've been doing that for years.
Right. And, I don't, not in terms of your listeners, I don't want to discount their family members who, if you've got a loved one who is struggling with substances, ranging from domestic violence to loss of financial stability to, horrible things happening in families because of the impact of the substance use. So it's not, this can sound like I'm being light and easy and we're talking in a loving way all the time. Like the invitation to change, it helps people actually really take care of themselves and strengthen themselves, so that they're engaging in a way that is effective and strategic and in line with their values, and also protecting themselves while their loved ones going through their process, which might take a while. So it's not, people will sometimes be like, I can't be nice to my loved one because they've, and I'm not discounting that. There's so much pain in some of these families, and you do need to protect yourself, but that doesn't mean you have to disengage. And that doesn't mean there aren't strategies that you can use over time that might really shift the dynamic.
Yeah. It's that pendulum swing where it's like the all or nothing. There is a gray in the middle, and will help you find your way. It's going to be messy. It's not always like those extremes often feel very good because our brains like identify that as feeling safe. Right. But
we love quick fixes.
We do love quick fixes, and you sharing about, like meeting people in their pain, and we talk about that with our clients as far as like, the substance use disorder or like the other behaviors, the binging, the purging, the restricting, whatever, like those are the tips of the iceberg. Like those are just the symptoms that we can see, but the 90% of the iceberg under the water is what's driving it. It's that pain. It's the, like you said, like the social awkwardness or the distress intolerance or the stress, the stress or the emotional and nervous system dysregulation. And, it's just so important that we remind everybody that that's really what's happening here, is that, like Clarissa, like you said, like the substance use disorder or the process addiction, whatever it is the solution. The problem is the stuff that we don't often talk about or can see. And so when we can flip that and start to have these conversations with family members, with community members, with other clinicians, with peers, it really starts to like shift the tide. And we've seen that in our own program. We heavily base our work in self-compassion. And it's so interesting because people are like, we don't know what to do with this. We're not even like, this is me giving myself permission. And we're like, whoa, wait a minute now. It's boundaried, right? When we talk about self-compassion, there's tender and fierce or ferocious. And it's it works together. And so it is fun to get to watch people like find kindness and compassion for themselves. Yeah. Yeah. So speaking about that 90% of the iceberg, sometimes for some of us, there are overlaps in substance use disorder with, neurodivergence or trauma. So like ADHD, learning differences, PTSD, CPTSD, all of those things. And so if treatment had been designed from the ground up by individuals with, those hurdles that they're also like working to overcome or surmount, what do you think would be different about it? Or like, how can we framework treatment for individuals with those, comorbidities?
Yeah. Thank you so much for bringing that up. Because I was just sitting here thinking about like the thing that is driving so much of this. I mean, if you look at the statistics, the rate of PTSD among people seeking treatment for substance use disorders is, 60 to 80% huge. Then you look at the ADHD executive functioning bucket, equally huge. So like, if you think about ground up, if we approached those problems and helped and understood those problems earlier, we could be preventing a lot of substance use problems. I think those problems are not dealt well. They're starting. I mean, there's more people talking about neurodiversity. And I mean, it's again, I'm like, as somebody who has ADHD, I look back at myself, I'm like, wow, I should have never been driving a car. I'm pretty convinced that my eating disorder behavior was probably 90% driven by just flat out unmedicated ADHD. And I was in years of therapy, like with exploring all the emotional reasons. And yeah, sure, there were some, but like now that I actually better understand my ADHD, I'm like, I would forget to eat. Just flat out forget to eat. Like I wasn't trying to be skinny. I would, like it was just like, I just forgot to eat. And then I would binge. And then I would be like worried about this or that. And just emotional dysregulation and being impulsive and all these kind of things. I'm like, had my ADHD been treated back then, I might have not struggled with any of that. I just didn't have a governor. I didn't have any braking system in my brain, and then being properly treated for ADHD, I'm like, oh, this is what it feels like to have brakes in my brain. Like that would have been really helpful. I've managed to do well in my life by creating all sorts of intensity for myself, in terms of like big goals and big workloads or whatever, which keeps my busy brain engaged in a constructive way. So I think I'm somebody who found work and sports and relationships and all sorts of things that kind of kept kept me from a more destructive path, in terms of what could have happened with my ADHD. But I think a lot of people don't, it impacts them greatly. And then they end up being kind of labeled as this monolithic addict, when it's like, actually, it's brain wiring, it's executive functioning, it's, the coping skills the executive functioning kind of coping skills that you didn't learn along the way, possibly because your family has the same issue because it's so genetically loaded. So, how are you going to learn these things in a family that maybe doesn't know these things either, so it's, we have to have some compassion for just all of that. And then the trauma piece, like trauma is so present in so many people's lives, in big and small ways. And people don't want to talk about it. That's literally kind of one of the hallmarks of the maintenance of PTSD, right? Is like, I have shame. I feel scared of that memory. I feel scared of that experience. So I'm going to do everything I can to avoid that emotional pain. So that doesn't happen in a meeting for the first time in therapy, hoping that you tell me what's going on, right? Like, you got to build trust. You got to build understanding. So the number of people who come to us seeking help for substance use, and I'm like, yeah, you're really struggling with X, Y, and Z substance, but I think what you're really struggling with is probably lifelong PTSD. And then you describe the symptoms and people will be like, I didn't even know I've just had that my whole life, or OCD, like I've just always done that. I didn't know it could be different, so just people living with enormous amounts of pain and not realizing that there are strategies that can really shift that for you. They're not quick fixes. They take practice. They take a lot of work, but you can learn over time to emotionally regulate in a different way. You can learn to manage your executive functioning struggles in a different way. There might be medications that are really helpful to you, but these are such nuanced conversations that take people a long time to even put everything on the table. And I say to families all the time, I'm like, therapists, coaches, we get 50 minutes with somebody once a week and we get what they tell us. And people don't always know what to tell us because, again, they've lived with it. They don't even know that they should be talking about it or that it might be helpful to talk about it. It's not that they're hiding it. And then sometimes they're hiding it because they've got so much shame about it, so it's just, I think just really having some compassion for these, again, just going back to this idea of like, this is such a complex problem. They're just so multi-layered and they're so human. They're just human problems. So if we could just be more compassionate and human, that would, I think, speed things up a lot because people wouldn't have to keep it a secret.
Yeah, they would feel safe, which I think is the biggest thing is they've just already, been shaming themselves and then society doesn't help, right? And how it's still so stigmatized around all those things that, yeah, actually what's really interesting that we interviewed somebody who was specifically speaking to neurodivergence and exactly what you were speaking about in your own, and how actually the purge can be the most emotionally regulating, grounding part of the behavior, which is reinforcing in itself. And so it makes so much sense, right? And how many people, what do they call those people? Oh, constant relapsers or whatever is the awful name that you feel, right?
Chronic.
Yeah, chronic. There you go. Oh, yeah. Yeah. I can't. I've blocked it out of my mind. I don't even like it that much. But it's like, oh, wow, that might be somebody who really struggles with ADHD because of their impulsivity and their inability to emotionally regulate. Yeah, I love that. So passionate.
And also, like, I, ate enormous amounts of sugar. I treated my ADHD with caffeine and sugar. I had, like
dopamine.
Give me the most Diet Coke and coffee you can give me and sugar. Like that's how I got myself through college and graduate school and everything else. I didn't know what I was self-medicating. I can see it now, but.
Yeah, no, so true. So you said you never diagnosed anyone with codependency, but what do you think is actually hiding underneath that label clinically? And how do you talk about with them in families where they understand it maybe in a different way, what's happening for them around the relationship with maybe the person that's has a substance use disorder?
Yeah, I mean, it's just one of those words that when you say like, well, tell me what that means. Explain to me the behaviors that you think make you codependent. You line 10 people up, it's going to be 10 different behaviors with 100 different reasons why they're engaging in those behaviors, so it's like, I have my own trauma. I worked with a woman, who for years, she almost lost a child, like really child almost died. Her other child struggled with substance use issues. She had a very hard time, like kind of setting and holding limits with him because, he would do and say things that would make her feel like I'm going to lose him too. And she had enormous PTSD, so she actually couldn't tolerate it. So that's not codependence, that's untreated PTSD. Like she just couldn't do it. So you can tell her she's codependent all day long. We actually have to help her with that trauma, before she's going to be able to do that. There's learning histories, there's family norms, there's cultural differences in terms of like, no, we actually we stay together as a family, no matter what, or whatever, the bazillion different reasons. It's just another word that I don't even know how to answer your question because it's such a word that just, again, whitewashes so much for me. I don't think there's a thing underneath that captures it all either. There's a bunch of different things underneath there. That non-answer. I'm sorry to give that.
No, but it's great. You actually answered it perfectly. And it made so much sense, right? Is like, there's huge fear about losing, your child to a substance use disorder. And there's so much going on. How do you talk to, or what do you suggest for, family members, individual therapy for themselves? Like, what would you say, from the families you've worked with, is kind of, if there is an evidence-based best practice for them? Because often what we see is like, oh, we send the person to treatment, maybe sometimes family members go to Al-Anon, but I'm wondering if you think that more support for family members is needed.
I absolutely do. We have a whole nonprofit designed specifically to help them, and are starting invitation to change groups across the country to try to provide support to people. The people running the invitation to change groups are peer support. Yes, there's some professionals, but the people that come to the trainings to become group leaders tend to be parents who've been through the kind of traditional treatment path. A lot of the parents are parents whose child has overdosed actually and died. And they come to the invitation to change trainings and they're like, my kid might be alive if I had this messaging, and it's heartbreaking to them, but they want to give it to other parents, so we've had those parents come and start invitation to change groups. And, it just, again, it gives people this frame. So everybody's kind of getting the same frame, but you're in these groups with people with real lived experience. And a lot of them go to Al-Anon and they'll do invitation to change too, because Al-Anon is just it's just a different animal. And and people build enormous community and support there and understand themselves better and take care of themselves better. But my experience is that most family members really want skills. They really want things that help them feel more effective in helping, because I've never met a parent who wants to cut their kid off. By the time they're at that point, they're heartbroken and crushed, and it's the last thing they can imagine doing. Meanwhile, that's often the advice that they get right out of the get-go, is to detach or be tough or whatever. So this just gives them alternatives and real skills that they can use and support for that. So, these invitations, our website, cmcffc.org, there's a resource tab. And in there's all these, and they're all free, they're free, low fee, support groups that people can sign on to. We're trying to, some of them have faith-based, group leaders, so we're trying to build a community where you can kind of find your community within that. Give me another year and it's going to be even more expanded. People can come to trainings and learn this strategy because, again, I think I'm a treatment provider. There's never going to be enough treatment providers. There's never going to be enough of us. And I think finding a way for lay people, friends, family, first responders, teachers, if we could all shift and have this frame, I think a lot of problems would be eliminated. We could just literally prevent a lot of these problems from happening if we intervened early on in a different way. And then if we gave people more ongoing support that, gave them the skills and helped them think about this as a behavior that takes time to change, right? And just give them the space and encouragement to do that over the long haul.
Oh, I love that. It's so community-based versus, it makes me think again, if we always frame it in this disease model, then we believe that somebody has to be an addiction medicine specialist or have all this extreme training because it is so big and scary because it's this big disease. But when we start to give people language and understanding and teach them, compassion and how to ask good questions or how to be like a good listener, it's amazing how like things can, like you said, become preventative or even like cut things off a lot earlier or really turn the tide on things. So maybe instead of this developing into full-blown substance use disorder, it's more like your experiences, like where maybe there was some heavy use at one point, but then something changed the tide of that, with the alcohol. It's your story about alcohol, where it's like, yeah, now it's like, I can take it or leave it. Like I have a different relationship with it in a whole different way. Right. Yeah. Yeah.
Yeah. And that thing that you just said about, because I think the hierarchy of that we're all, that there's an expert. And I think the addiction treatment world in particular has done this a lot where, family members will call and treatment providers will say, if you don't do this, X, Y, and Z is going to happen, right? Or, this is what you have to do. There's a very prescriptive top-down message. We're the expert. This is what you need to do kind of thing. And, I do this all the time. And it's always interesting to me when I say to a parent, often who feels terrible about their parenting because their kid's struggling. So they automatically think I'm a terrible parent. When I say, like, you actually know your kid, you know so much about your kid. Tell me what you know. Tell me what you know is going to probably work for your kid. They have a lot of information. They just haven't felt like they could offer it up because they were told they needed to do it in this other way. So, I think I'm skeptical of expert stances because, I've been doing this a long time. I know a lot. I don't know everything. And I'm constantly, like, every single day, I'm like, wow, I didn't know that. That's cool. Like, there's a lot more for you to learn.
I love that too. It's the same for the clients we work with, right? It's like, you have whoever I'm working with, I'm like, you actually have all your answers. Let's just like find you.
Totally. Yeah. 100%.
Right? Together versus.
A lovely, lovely way to phrase it. Yeah.
So you mentioned the website. Is that the best place for our listeners to find you?
Yeah. The nonprofit is cmcffc.org. So that's designed for family members. That's got all the ways to learn the invitation to change as a family member. And then those free support services. There's on that, there's, we have, oh my God, Beyond Addiction. What's the title of my book? I don't know.
Yeah, I have the label too. We'll make sure we're going to put them in the show notes too. Yes. Yeah. So you have the workbook too, which is.
Yes. So that is the invitation to change, the Beyond Addiction workbook. And then the book itself is Beyond Addiction, How Science and Kindness Help People Change. So there's written material. And then the treatment programs are the Center for Motivation and Change. So those, there's formal treatment, but I'm actually a much bigger advocate of the FFC and the books and, really wanting, that's our way to disseminate this information to the world as far as we can get it. And like, we have lots of treatment professionals and sober coaches and come to the invitation to change because it just changes their practice and it changes the way that they engage with clients. So it's professional. It's for professionals and family members. And it joins you to a lovely community too of, being able to just talk this language.
Yeah, I feel like we need to go there and find more people. So we do have one signature question and we always tailor it to our guests. So for you, we made it, if you could tell a younger version of yourself something about how to help people in addiction recovery, what would you say to her?
Be a little more patient.
I feel like that is the best answer. It's the most truthful answer.
Because, when I first started, all the things that I said earlier, like these problems are scary to witness and they're painful to witness, so I definitely was like, let's move this along. Let's go quick. Let me give you everything I got, I was always doing it from a motivational stance. So, I think and the CMCs wouldn't exist if I didn't have some success in that, but I have way more patience for just an acceptance of just how slow and painful this can be, which is why the self-compassion work really helped me be able to slow down and be with somebody who was moving at a slower pace than I would like them to. I would like them to speed up and not harm themselves along the way, but you can't rush it, you just can't. So you can encourage it, you can support it, you can grow it, you can, but I think being patient with it ultimately is the most effective.
Yeah. Well, thank you so much for being here today, Carrie.
Yeah, thank you so much. You guys have been really nice to talk to.
Thanks for joining us this week on Food Junkies Recovery from Food Addiction. Make sure to join our Facebook group, Sugar Free for Life Support Group, I'm Sweet Enough. Molly and Clarissa are food addiction professionals who offer one-to-one counseling and group coaching through Sweet Sobriety. Please subscribe to our show so you never miss an episode. While you're at it, if you found value in today's episode, we'd appreciate you leaving us a review on your favorite platform. Your feedback helps grow our show and allows us to reach others who need to hear this message of recovery. Don't forget to pick up a copy of Dr. Tarman's book, Food Junkies. And as Vera always says, the power is ours.